Welcome to this explainer. Today we're going on a virtual shift ride along to decode the exact, hyper-precise vocabulary and structured protocols that medical responders use to literally save lives. Whether it's an ambulance weaving through city traffic or a completely jam-packed emergency room, the words spoken by healthcare pros are rarely just casual conversation. They're highly calibrated instruments of survival. But before we really jump in, I want you to picture this high-pressure scenario. Imagine arriving on a scene, and your patient is completely unresponsive. Total chaos is swirling all around you. Do you know exactly what to say and what to do? Well, by the end of today, you're going to learn the exact words, the precise phrases, and the systematic assessments needed to bring order to that chaos. We're looking at the specialized language that EMTs and paramedics use to turn pure panic into actionable, life-saving protocols. So here's our shift briefing for today. We'll be moving chronologically, starting with the initial patient encounter, then the ABCDE assessment approach, decoding that complex emergency medical jargon, taking a focused history, and finally handling triage and major incidents. All right, let's dive into part 1, the initial patient encounter. The clock starts the absolute second an EMT arrives on the scene. Now, before any advanced medical interventions can even begin, the very first thing a responder has to do is establish communication and control. Imagine you're stepping into the cramped back of an ambulance, getting ready to take a handover for a patient in extreme distress. The lights are glaring, it's tight in there, and the person in front of you might literally be having the worst day of their life. How do you even begin to speak to them? You have to build instant trust, while at the exact same time gathering critical data. Well, you start exactly like this. Hello, my name is Tim, and I'm an emergency medical technician. It sounds incredibly basic, right? But this quote comes straight out of the English for EMTs workbook, and it is the gold standard for that very first interaction. By stating your name and your title, you establish immediate rapport and a solid professional bedside manner. More importantly, though, this simple introduction is the crucial first step in getting what we call expressed consent, which is just the verbal or nonverbal acceptance of medical care. You can't just start poking and prodding a conscious patient. You have to use language that actually invites their cooperation. Once you've got that consent, you have to rapidly gather demographic data for the pre-hospital care report: name, age, address, medical insurance. But in an emergency, absolute accuracy is quite literally a matter of life and death. In fact, training emphasizes asking the patient to actually spell things out for you, like, did you say M as in Mike or N as in November? A single spelling error in a postcode could mean your backup arrives at the wrong location, or a critical patient's medical history can't be pulled up at the hospital. Moving right along to part 2, the ABCDE assessment approach. Now, if you encounter a patient with absolutely no signs of life, you immediately shout for a team member to put out a crash call. But if they're alive, albeit critical, we jump straight into the ABCDE approach. This is a rigid, non-negotiable, life-saving checklist used by emergency teams all over the world. You do not deviate from this order. A stands for airway maintenance, strictly with cervical spine protection. Securing that airway is your absolute #1 priority, because if you don't have an airway, nothing else matters. Then you move to B for breathing, C for circulation, D for disability, which is checking their neurological status, and E for exposure, meaning you're checking the entire body for hidden injuries while keeping their temperature safe. So when you're assessing that airway, you've got to constantly ask yourself these rapid-fire questions. Is the patient talking? Because if they are, hey, their airway is at least partially open. But you're also listening super closely for something called stridor. That's a highly specific medical term for a harsh, high-pitched sound in the upper airway, which is a massive red flag for a partial obstruction. You're watching for chest movement, you're listening for snoring or gurgling, and you're figuring out if you need to use maneuvers like a jaw thrust to open things up. As we move down the checklist to circulation and disability, we rely on very specific tools and the vocabulary that accompanies them. Take pulse oximetry. This measures the oxygen saturation of hemoglobin, giving us a vital sign that shows how well the patient is breathing on a cellular level. It lets us rapidly spot signs of hypoxia or cyanosis, which is that dangerous bluish tint caused by low oxygen. And for disability, EMTs use the Glasgow Coma Scale, or GCS, to calculate brain function by scoring eye, verbal, and motor responses. Every single finding gets verbalized out loud to the team leader, so absolutely nothing slips through the cracks. Let's move to part 3, decoding emergency medical jargon. To communicate these vital signs efficiently to the hospital, EMTs translate
everything they're seeing into precise medical jargon. Now, to a bystander, this might sound like a completely foreign language, but it's designed for absolute clarity. A simple nosebleed is formally reported as epistaxis. What looks to you and me like bruising is reported as ecchymosis. Why use these complicated words? Well, because in medicine, bruising could mean a dozen different things, but ecchymosis has a very specific clinical definition about blood escaping into the tissues. It removes all ambiguity when you're handing that patient over to a trauma surgeon.
And everyday words can have completely different, potentially lethal meanings in emergency medicine. Take the word shock. To the general public, it just means you're emotionally surprised. But to an EMT, shock means inadequate tissue perfusion, a critical, life-threatening lack of blood flow and oxygen to the organs. And when that lack of blood flow actually causes tissue to die, we call that an infarction. We see these specific terms combined in our most critical diagnoses. An acute myocardial infarction, or an AMI, is the precise clinical term for a heart attack. It literally means the acute death of heart muscle tissue. Anaphylactic shock isn't just a bad peanut allergy. It's a severe, life-threatening allergic reaction that causes systemic hypoperfusion. And a word like eclampsia instantly communicates pregnancy-induced seizures. Having this specialized vocabulary allows professionals to convey incredibly complex conditions over a crackly radio without wasting a single precious syllable. All right, on to part 4, taking a focused history. Once the immediate ABCDE life threats are stabilized, we shift gears. Now we have to hunt for the nature of illness, the NOI, by taking a highly focused medical history. Imagine you're with a patient who has a terrifyingly silent chest. They're barely making an effort to breathe, they're slipping out of consciousness, and their pulse ox is sitting at a dangerous 92%. A silent chest means absolutely no air is moving. This is severe, life-threatening asthma. In this exact moment, you need to know precisely what questions to ask to gather their history while simultaneously getting high-flow oxygen and cardiac monitoring set up. To do this quickly, EMTs ask highly specific red flag questions. If it's an abdominal emergency, you don't just say, "Does your tummy hurt?" You ask about coffee ground vomiting or melena, which immediately indicates severe internal GI bleeding. You ask about NSAID use, which can cause ulcers. For gynecological emergencies, you have to explicitly ask about a history of ectopic pregnancies. For dermatological stuff, you're asking about blistering or the exact onset of a rash. You're basically mapping specific clinical phrases directly to anatomical systems to rapidly zero in on the root cause. And finally, part 5, triage and major incidents. So what happens when the emergency scales up to a mass casualty event? Well, the normal rules of communication change instantly. In a lot of emergency departments, dialing 2222 tells the operator you need an adult cardiac arrest team stat. But in a major external incident, standard procedures get overwritten. Early command and control is activated, often organized into gold, silver, and bronze commands. Individual patient names actually become secondary. Instead, every patient is slapped with a unique major incident number, just so they can be tracked through the chaos. From there, you shift into a strict, ruthless triage cascade. Patients are rapidly categorized. Priority 1, or P1, means they need immediate resuscitation to survive. Priority 2, P2, means serious injuries needing urgent intervention, but they aren't dying that very second. Priority 3, P3, are the walking wounded with moderate to minor injuries. It sounds cold and calculated, but this language of triage is absolutely necessary to strategically manage your limited resources and save the maximum number of lives possible. Wow, okay, we've covered a ton of intense ground in this explainer today, from the initial "hello, my name is," all the way to managing a P1 mass casualty triage. Knowing this specialized language is one thing, but I'm going to leave you with this final thought. Homeostasis is the medical term for a state of internal balance or equilibrium. Could you maintain your own mental and emotional homeostasis if you were the one stepping into the back of that ambulance, taking a handover for a real life priority 1 emergency? It takes a very special kind of person to speak the language of life and death clearly when every single second counts. Thanks for joining me today. Keep learning and stay curious.